Have you ever thought about a condition where the very thing you need to live, food, is also the source of just awful pain? It's a real medical mystery that can turn something as simple as dinner into something you dread. Well, today we're going to pull back the curtain on this exact condition. It's called chronic mesenteric ischemia.
In fact, doctors have a name for what this does to a person's mindset. It's just two words, but they are incredibly powerful. Food fear. And that's exactly what it sounds like. It's a completely irrational fear of a pain that on the surface seems to make no sense at all. And that's really the core of the problem here.
So, that's the big question, right? Why on earth would eating, something so basic and necessary, cause so much agony? To figure that out, we're going to follow the patient's entire journey, right from the first confusing symptoms to the final solution.
Okay, let's start where it all begins, with the patient's own experience. To really get it, you have to put yourself in their shoes. We're not talking about a simple stomach ache here. This is a bizarre and totally life-altering pattern of pain that at first feels like it came out of nowhere.
So here's what it looks like. About 10 or 15 minutes after you finish a meal, this pain starts up right in the middle of your abdomen. It could be a sharp cramp, or it could be this nagging, dull ache, and it can stick around for hours. So what do? You start to change things. You eat smaller meals. Maybe you avoid that food you think triggered it, or you might just skip eating altogether. And that leads directly to the biggest clue for doctors: major, unintentional weight loss.
And here's the really tough part. On average, it takes a year and a half, that's 18 months, from the time these symptoms first appear for a person to finally get the right diagnosis and actually get a shot at treatment. Think about that. A year and a half of this food fear.
So what is actually causing all this pain? Honestly, the best way to picture it is to think of a traffic jam, but it's not on a highway. This is a traffic jam happening inside the arteries that supply blood to your gut.
And that traffic jam has a name: Chronic Mesenteric Ischemia, or CMI. It just means that the arteries carrying all that oxygen-rich blood to your intestines have gotten narrow and flow is restricted. Now, your system can kind of cope with this when you're just sitting around, but it completely fails when it's under stress. And for your gut, the biggest stressor of all is trying to digest a meal.
This number really highlights the incredible demand we're talking about. After you eat, the blood flow to your intestines can more than double. It needs all that extra oxygen to do its job of absorbing nutrients. It's a huge surge of demand, but if those arteries are blocked, that demand just can't be met.
Okay, this is a really fantastic way to understand CMI. Let's compare it to something you've probably heard of: heart angina. With heart angina, if you exert yourself, say you run up a flight of stairs, you get chest pain because your heart muscle isn't getting enough blood, right? Well, with intestinal angina, it's the exact same idea. Eating is the exertion, and you get abdominal pain because your intestinal muscles aren't getting enough blood. Same problem, just a different muscle group.
So what's causing these blockages in the first place? Well, in about 90% of cases, the main culprit is atherosclerosis. It's that same sticky plaque buildup that causes heart attacks and strokes. Now, the cool thing is, your gut has this amazing backup system. It has 3 main arteries feeding it, plus a whole network of smaller ones. And because of this redundancy, the disease can be totally silent for a long, long time. The tipping point usually comes when at least 2 of those 3 main arteries get severely blocked.
Okay, so we get the cause. Now let's look at the diagnosis. Once a doctor starts to suspect CMI, how do they prove it? How do they actually see inside those arteries to find the traffic jam?
It's usually a two-step deal. Step 1 is a screening test called a mesenteric duplex ultrasound. It's totally non-invasive. It just uses sound waves to measure how fast the blood is flowing. If the blood's moving way too fast in one spot, that's a big clue there's a narrowing. If that test looks suspicious, then you move on to step 2 for confirmation, a CT angiography or a CTA scan.
And this CTA scan, it's really become the absolute gold standard for a reason. It gives surgeons this incredible high-resolution 3D roadmap of the arteries. It shows them exactly where the blockages are, how long they are, how much calcium is in them, all the nitty-gritty details they need to plan the perfect attack.
And that brings us to the treatment itself. Once CMI is confirmed, the goal is pretty simple: get that blood flowing again. But for patients, there are 2 very different paths to get there, 2 ways to find relief from the pain.
Path number 1 is the minimally invasive route: endovascular stenting. A surgeon makes just a tiny little puncture in an artery, usually in your arm or your groin. They then thread a super thin wire up to the blocked artery in your belly. And then they deploy a stent. It's like a tiny metal scaffold that expands and just pushes all that plaque out of the way, propping the artery open. It's a really elegant, high-tech fix. Path number 2 is the more traditional, old-school approach, open bypass surgery. This is a much bigger operation. It involves a larger incision in the abdomen, and the surgeon literally reroutes the blood flow. They take a new vessel, a graft, and they sew it in place to create a brand new detour for the blood to go around the blockage. So, a much bigger deal, but as you're about to see, it has some major upsides. So you've got these two very different options. How in the world do doctors and patients choose between them? Well, it all boils down to this central conflict that we can call the durability dilemma.
This quote just nails it. The choice is all about short-term ease versus long-term durability. In other words, are you trying to make things easier with a faster recovery right now? Or are you aiming for a fix that's much more likely to last for years and years? That's the trade-off right there.
And these numbers, they lay out that trade-off perfectly. Look at the short-term stuff. The stent wins, hands down, way fewer complications, and you're in the hospital for maybe 3 days instead of 2 weeks. But then look at the long-term story. The chance of your symptoms coming back is much higher with a stent. And that last row, 5-year durability, that's basically asking, is the artery still wide open 5 years later? The bypass is dramatically better. And if you're a visual person, this chart just says it all. The chance of your symptoms returning is more than double with a stent compared to open surgery. That's the dilemma in a single picture. A much easier procedure that is also, unfortunately, much less durable. So, after navigating that really tough choice and getting the treatment, what does life look like? What's the final chapter in this journey for patients who've been through it all?
Well, the good news is the outlook is really positive. Both procedures are fantastic at getting rid of the symptoms. Over 88% of patients get their lives back. They can eat again without fear. But it's not quite a one-and-done fix. Because atherosclerosis affects the whole body, you need lifelong checkups with ultrasound to watch for new problems. And interestingly, when you look at long-term survival, it's not about which procedure you got. It's about a patient's overall health, things like heart or lung disease. But wait, the story isn't over. Technology, of course, never stands still. And there's a huge innovation that's starting to change that whole durability dilemma we've been talking about. There's a new generation of stents called covered stents, and they are showing absolutely remarkable results. At 3 years out, their durability is at 92%, which is almost the same as the big open surgery. This is a potential game changer. And that leaves us with this really fascinating question for the future, right? We've seen this happen in other parts of medicine, where the less invasive option eventually gets so good that it matches the durability of the big open operations. So will this same thing happen here? Are we going to get to a point where the choice is no longer a dilemma at all, but just a simple preference for the easiest path to a fix that lasts? Well, only time is going to tell.